I'm Chris Kaiser with MedPage Today at the European Society of Cardiology meeting in Paris, where the ESC has declared it the year of the Registry. I'm here with Dr. Robert Bonow, a professor of medicine at Northwestern University in Chicago and a past president of the American Heart Association. Welcome, Dr. Bonow.
Thank you, Chris. Delighted to be here.
I'm glad you're here as well. First, I'd like to ask you, why is it important to have registry data?
Well, it's a good question, and I'm glad that the European Society has highlighted this year, because it's important not only in Europe, but also very important in the United States. And in fact, in the United States, we've been dealing with registries for a number of years. It's important throughout medicine, and of course, as a cardiologist, I see this as being very important in cardiovascular disease in particular. Because in cardiovascular disease, we've got enormous data from clinical trials that provide the evidence for our guidelines and the recommendations we put into how to diagnose and treat our many patients with all forms of cardiovascular disease. The problem is the clinical trials don't pertain to all the patients we see in real life. Some clinical trials exclude elderly people. They may exclude people with coexistent diseases like diabetes or kidney disease. They may exclude younger people in some cases, whereas registry data give us more real-life information about some of these conditions as we actually see it in clinical practice, because our patients in clinical practice are elderly. They do have comorbid diseases, and it allows us to begin to acquire data that helps to provide extra information on top of our guidelines. Now, in other aspects of medicine where they don't have clinical trials as we do in cardiovascular disease, the registries are very important, because then they can begin to acquire some data that have not already been formulated a little bit in clinical trials. Also, clinical trials don't address all the questions. They may be developed for a new drug from a drug company, but if that's the case, we're never going to see comparative information from drug A versus drug B in a clinical trial, because we'd have two drug companies competing with each other. And the NIH budget usually doesn't allow us to do those kind of trials. Whereas with registry data, we can get information regarding patients on drug A and drug B and get a feeling for, whether or not there's a better outcome. And then finally, and probably for me most importantly, is when we acquire registry data from large samples throughout the United States, for example, as we have done, both from ACC and American Heart Association registries, some of which are now combining, you begin to see differences in the patterns of care. And you find that some doctors or some hospitals are providing excellent evidence-based management of their patients, whereas other physicians, other hospitals may be less up to speed with following guidelines or recommendations. And so the processes of care, you see gaps in care. And then you can build into the registries feedback to the physicians involved, and maybe develop quality improvement initiatives built into the registry to actually show improvement in care over the course of time. And registries also allow us to track outcomes. Are patients living? Are they dying? Are they having heart attacks? And are they living better quality of life as well? So registries actually do add a lot to what we already obtain from our clinical trial data.
And that's what I was thinking about. The clinical trial data essentially is telling us, and I'm simplifying this, that a protocol or a drug or a treatment is safe and efficacious.
Yes.
Whereas the registries are going a step further, and they're actually identifying some quality issues.
Yes.
Can you talk about that?
Yeah, well, from the guidelines we have in cardiovascular disease, and again, we're somewhat unique in the cardiovascular community because many areas of medicine don't have this, at least not yet. We have a number of guidelines recommendations from which we develop performance measures. In other words, after a heart attack, a patient should go home on a beta blocker and an aspirin. How well are we doing that? And so we actually have performance measures built in that the hospitals will identify how many patients are going home on beta blockers and aspirin. That can be easily acquired information, and one can then determine whether hospitals are performing up to speed or not. And again, this can be done without registries, but the registry data allow us to then begin to acquire all that information and see whether hospital A and hospital B are living up to the same standard or not. So we do have quality performance measures that have been developed from the ACC-AHA based upon their guidelines that have been published and implemented for acute myocardial infarction and heart failure and atrial fibrillation, other conditions as well. And you do see that even when you have those performance measures that you should be doing this, all of your patients should be receiving ACE inhibitors and beta blockers. There's wide variability in care. In fact, the Medicare data, the Centers for Medicare Medicaid Services, CMS, has a website that anybody can log into to determine how different hospitals are performing. How many patients after an MI go home on a beta blocker, and there's wide variability out there. Now, registries allow us to accumulate that data. If hospitals are contributing to the registry, they can get feedback as to how well they're doing.
You can identify outliers on either end.
Exactly, and in doing so, perhaps build in some quality improvement processes to get everybody up to speed. So that kind of information can be quite helpful.
Okay, so you've mentioned the registry data that the United States has been gathering for a number of years now. Why all of a sudden at this meeting does the ESC declare it to be the year of the registry?
Well, I think, first of all, I think it is the year of the registry even in the United States, because now at the national level in the US, there's a growing awareness of the importance of registries like that. Because what happens if you have a registry from the American Heart Association on patients with coronary disease who have diabetes, and the American Diabetes Association has a registry on patients with diabetes who have coronary disease? Well, they're probably the same patients. Let's start getting a global registry. Let's put all of our data together as best we can, or at least allow us to link these data back and forth. And if we have quality improvement initiatives, like a patient with coronary disease and diabetes should be on a statin, and we have registry data, and the American Diabetes Association also has registry data, let's start seeing what's going on, really. And so there's a growing awareness in the US that this is also the year of the registry. Now in Europe, I think it's a little awakening that this is an important thing they've been doing in Europe. Now they have registries in Europe already. They have the Euro Heart Survey, which has been very important. And Europe is a little more complicated than the United States, because you've got national boundaries and cultures and languages and economic issues, of course, from east to west. North and south, and I guess those are also becoming more difficult these days, as they are in the US. And so there's wide variability in care in Europe. That's been demonstrated already. And I think what we're hearing now is let's get more data on what's going on in Europe, and maybe also link some of those European data with the US data and elsewhere in the world, and see if we can't make a difference in the overall outcome of all the patients globally with heart disease.
Okay, thank you, Dr. Bonow.
Thank you, Chris.
I'm Chris Kaiser with MedPage Today, InFocus.